Good morning, everyone. Hello over here on Facebook. It's time for yet another NeuroCentric approach coffee club case study. I've got my holiday red hat on, got my brain tea going on here. Some of Dr. Anthony Gustin's perfect keto ketones in there, some MCT, and we'll catch up on the week as folks join us here. I hope you guys are having a good week and are still recovering from your atmospheric river. It's been quite moist here in the Pacific Northwest. I see Dr. Mark Heller joining us here on a walk in what appears to be a beautiful Ashland day. I hope things are going well for you there, Mark. Let's see. For those of you that are uninitiated over here on Facebook, this is a weekly meeting that we do of case studies to highlight the NeuroCentric approach, which is a integration of several different areas of emerging research over the last 10 years. And it's my attempt to try to bring them all together to get them into clinical care a little bit better. And because it's a somewhat difficult process, a systems-based process, if you will, it's a bit difficult sometimes for a clinician to keep themselves organized and keep their eye on the ball without getting too overly structurally fascinated, I think. So what I've attempted to do with all of this is put together a rubric, heuristic, if you will, to put a couple of words on it that make me sound smart. To keep you organized while you're doing that. There is a link on the Facebook bit there over at neurocentricapproach.com. We have an online academy. You can pay one time and get 35 plus hours of continuing education recorded. And when you're a lifetime member on that, you will get $100 off of upcoming in-person courses. In the last week, it is worth noting, we've had a bit of a change in the overall organizational, call it the leadership of NeuroCentric approach. And I am going to be focusing entirely on this now. I will be the principal at NeuroCentric approach. Dr. Dean's plate is full enough in other areas that he is going to focus on those things. So you've got me one-on-one with NeuroCentric approach along with my current associates. If we, and that means that future courses in person, I will be the lead instructor on that and assisted by my associates and former students as needed. So that is order of business to be taken care of there. For my Jewish friends in the sphere out there, happy third day of Hanukkah. I hope your festival of lights are wonderful in your own particular corner of the world. As we typically do with these meetings, I'd like to each week try to bring a specific case and from my own work and talk about that. And then we'll do old business and then new business. You guys that are watching are more than welcome to bring your own cases on too. And just hit me up during the week, especially you guys that are members over here, and let me know, hey, would it be okay to talk about this? And what we generally try to do is a standard case conference presentation, the same kind of thing that is relatively structured in a medical environment. For those of you that are familiar with that, you come and talk about it like you did in your student days. Patient presents as a, I don't know, 42-year-old female with a 10-year history of lumbosacral pain, averaging baseline 4/10 pain. This is exactly our case conference today, by the way. Et cetera, and then palliation, provocation. So your locus mat, or your however you learned it in school, you want to present like that. Then you want to present that's your chief complaint. Then you want to talk a little bit about their past health history, their family history, and their social history, and how all those things are contributory. And then we'll take all of that and we'll tilt it, I'm going to say about 45 degrees. I don't think we even need to go 90 degrees. We're just going to tilt it a little bit to look at it from a neurocentric approach lens, which means that in your history, you're going to pay specific attention to the 4 buckets of epigenetic influence into possible neural sensitivity. So that will be sleep, unmanaged stress, lifestyle issues, and diet. And under lifestyle issues, that typically has to do with 2 subcategories. What degree of willful self-poisoning they're doing in terms of drinking and drug use, and whether or not they're exercising, and if they are, how much and what they're doing for their exercise. So that will catch in the history. The other thing in the history from a neurocentric approach lens we would be quite interested in would be their prior health history, their prior diagnoses, what they've been told about the condition that they have, their prior health history and diagnosis, what their belief systems are about what it is that's going on in their body. Prior diagnoses of things like HIV status, and possibly or cancer status, or diabetes status would all factor into things that could cause some sort of polyneuropathy and have some peripheral nerve sensitization issue. So those are the kinds of things we want to investigate in history and such. So towards that, let's jump right into old cases and new cases. Some of you might have seen some of the cases that I have presented in the past 2 months. They're up on the blog section of NeuroCentricApproach.com. You'll find a transcript and a recording of these conversations in that. Chris Harris, it's nice to see you here, my friend. I hope you're doing well in North Carolina. And I would really love to have you on here, if only just to joke back and forth, and maybe even bring your mother on at some point. What a delightful relationship there. The prior of our old case that we presented most recently, I think it was last week, was a ping pong player, 73-year-old guy with right hip pain when performing a forehand smash or a golf shot. His pain was primarily in the groin and some in the anterior hip. And he also had lateral hip pain with squatting to a half squat depth. And we put some interventions on. You guys might recall that I was able to get some transient benefit working sort of a DTM model, right? We used an offloading process with DTM over the putative area of the obturator nerve in the medial thigh, medial proximal thigh, more specifically over the interface point where the obturator nerve goes between the adductor muscles in that septa between the most proximal adductor muscles, and can sometimes be vulnerable to an entrapment syndrome at that particular area. Did some work there and got some transient benefit. We worked laterally around the flank over the area where he was hurting in the lateral thigh, which correlated to the lateral branch of the iliohypogastric nerve. We got some transient benefit in his index movements of the forehand smash, golf swing, and squat. But they were only transient. So we continued our exploration. In this case, we worked from peripheral to proximal and worked back upstream and did static openers for the spine, for the lumbar spine, and we got some buy-in there and got much more long-lived improvement in that patient's presentation. And he was quite pleased that all of his pain was gone after performing those static openers. Okay, so that was cool. Our working diagnosis was we had essentially a spondylosis-driven osteoarthritic condition, creating some stenosis at an upper lumbar, probably an L4 neural radicular kind of situations going on there. Sent the patient home with that information. He had a relatively sophisticated understanding of things. He's has worked in tech for a number of years and was a teacher. He was a delight to work with and a bit of a geek. So he was very receptive to my sometimes long-winded explanations of things. And he came back this past week. His pain was better, but this is a key point. He said something that we will often hear in our patients when we're working these models that only bring a transient benefit. He was happy, kind of, not ebullient about his pain reduction, but he wasn't, over the moon because the pain kept coming back. So two things, to my mind, needed to be discussed at that point. One was we need to frame expectations appropriately. This patient may actually be a surgical candidate for, a roto-rooter procedure at that particular level, or some sort of, osteotomy or laminectomy or something of that sort. So we refer to it that way. But the other thing, since we're playing with nerves in these cases, and those nerves are not uncommonly amenable to opening procedures where we can offload the nerve for a period of time and see this kind of benefit, we can pull a page out of McGill's work and stack benefit. So, for instance, in this patient, I drilled down on the benefit that he perceived from the work that he had gotten when he did it himself. So when he did the corrective exercises, he felt benefit. And I'm like, okay, so how long does the benefit last? And I got a range, and his range was, depending on what he was doing, 30 minutes to 2 hours. Okay, that's pretty darn cool. But I suggested that he pay a bit more attention to that, and he try to find a place where he can come into that repetition of the beneficial exercise and do it more frequently, preferably before the onset of the next bit of pain. There we're working a bit of a top-down process so that he becomes a little less expectant that he's going to hurt with a specific movement. And the other is a peripheral nerve physiology issue, leaning into Jeff Bove's work. If we have some sort of a compressive or less commonly a tensile phenomenology that is reducing blood flow to a nerve and possibly reducing axoplasmic flow, then that will alter the metabolism of the nerve itself. And you'll wind up with some changes in connective tissue organization within the nerve, which alters its elastic modulus. That's a later thing for us to deal with in our rehab programs. And on the front end earlier, we generally see that when we improve the perfusion of a nerve that is having poor perfusion, that very quickly we have changes in pain, less commonly numbness and tingling. But here's the other one. We commonly have changes in strength. Now, that goes against what many of us were taught in school, that those strength changes were very late to come on. So if we do our motor tests in the way that we learned them in NCA, which is typically a patient-performed motor test, which is more objective. In this case, if we're testing S1, I'm going to have them do repetitive single leg toe stands and try to get to 20 reps or so. And then I'll have them do 20 reps of single leg heel stands and try to get to 5 reps or so. Those are just numbers that I've have adopted over the years in playing this particular model, which is an expansion of a paper by a researcher by the name of Suri, S-U-R-I, where he had people to walk on their heels or walk on their toes to try to get more objective data there. What I'm looking for is a more objective way of quantifying the motor weakness than a manual motor test, 5/5 kind of thing, which many of us have experienced to be a highly subjective way of testing motor strength. But you can often, I have found over the years in working this model, you can often find that you can do these procedures on the involved neurology and get a reduction, not only in a reduction in pain, but also an improvement of motor function. And since motor function, the diminishment thereof is one of the primary drivers of pushing that patient out of your clinic if they've got progressive motor weakness, that's worthwhile for us to pay close attention to. And then it also anchors the patient around something that they can do on a regular basis to determine what their trend is. And then you've got the patient helping you in between visits, tracking data that will give you some kind of clinical trigger point of whether or not you're going to continue to work with that patient or whether it's time to send them on to a more interventionist kind of an approach. So we did that. This particular patient is a snowbird, and they are going to the Phoenix area. So I'm sending them to clinicians down in that area that know this kind of work. And hopefully they will continue to improve. In this particular case, I then went in and did, I put a McKenzie flexion pattern on him. I put a static opener on him, had him to increase the frequency of that. And then I went in and did TNM and DTM, that's transverse nerve mobilization and dermal traction method over the involved peripheral neurology. And then I manipulated his spine and manipulated his hips and did some more mobilization in his hips. And he was unable to reproduce his pain when he left the clinical encounter, which according to the CAP clinical audit process would suggest that long-term he's going to do okay. So there's old business, old case study. If any of you guys have any questions on this one, then feel free to weigh in. It's going to be difficult for me to field questions over here on Facebook. You guys should be members. Follow the link there. get 35 hours of online continuing education. So you can come play with us over here on the Zoom link and manage questions throughout the week and brainstorm on this kind of stuff. Seriously, guys, there's a hell of a lot of value in your continuing education right over there on that link on Facebook Live at neurocentricapproach.com. Chris Sasaki just joined us. Welcome, Chris. Nice to see you here, brother. I am also wide open. I know Chris is going to respond to this because he has in the past, trying to get us, I say, and I need to change that to trying to get me to come and teach an in-person course in Seattle. We will be going up there. I'm not sure exactly where. Chris, you were a little bit, I think you were the third person in Seattle to hit me up for a site. So we'll run into each other at some point there. Okay. I do not see any questions over here on the Facebook, nor do I see any questions regarding that case over here on Zoom. So I'm going to plow into this week's case study, which is a real live SI joint. Many of you that have been playing with me for a while, especially through the clinical companion of to Fix Your Own Back, which, by the way, is basically the neurocentric approach leveraged towards back pain, more specifically towards the disc injured back. Know that I am not quite as enthralled about sacroiliac joint, quote unquote, dysfunction. Yeah, we can find it. How do we find it? Using the best available orthopedic heuristic that we have there, which is the Laslett cluster from Mark Laslett. The inclusion criteria on that is the patient doesn't improve in pain or have any centralization phenomena noted with repetitive end range extension. So typically you wouldn't even launch into that until you'd applied that McKenzie process of end range extension and seen no benefit or possibly worsening. And indeed, in this particular patient, which was a 41-year-old female veterinarian, emergency vet, with a 10-year history of lumbosacral pain, onset occurred when she was kneeling in a tub, outside of a tub, bathing her young child, and reached over to grab them and felt a pulling sensation in her lower back. Got Eric Haroldson joining us over here. Welcome in, Eric. Nice to see you here this morning. So back to our case study, 41-year-old female vet getting her child out of the bathtub 10 years ago. She had immediate pain in the lower back. It was her first back pain episode. She reported that since then, she has had ongoing pain that is 100% of the time present. That is 4 to 5 over 10 in severity, and worsens to about a 7. It's typically worse with prolonged standing. It's worse with backward bending, and it's worse with her lifting, which she has to do a fair bit of in her work as a veterinary as a veterinarian and an emergency vet situation where often there's lots of interesting lifting and such that's involved. To try to get benefit, so that was provocation, now palliation. She has not had a whole lot that helps her, but she gets acupuncture every other week, and the acupuncture every other week tends to help for just a short period of time. She tried seeing, she was referred over by her naturopath, and the naturopath is actually a patient of mine who deals with a lot of very chronic pain conditions. And the patient was not very interested in coming to see a chiropractor because 3 years ago, they had been to see a chiropractor and saw them 3 times. And the chiropractor noted an SI issue, and the SI issue they tried to manipulate, and the patient reported that they felt worse after every visit, and their words were they felt traumatized. So continuing on in our Locuzmat, they did not have a history of radiation. They did not have a history of any numbness or tingling, and no saddle paresthesia, no changes in bowel or bladder, current or past, associated with this. No other past health issues that raised a suspicion of any other kind of untoward contributory issues, but interesting other things going on in their life and past health. A couple of years ago, they started to experience PVCs, which were extensively investigated. She wore a Holter monitor twice. According to her, the follow-up with the Holter monitor with the electrophysiologist did not note any specific pathology, which makes me wonder how she had a diagnosis of PVCs. And as I leaned into that, she felt that she was having PVCs. Reminder here, she's a veterinarian and a self-professed geek. She's been trying to sort her issues here, and it became more apparent that she was self-diagnosing the PVCs. She was not tracking them using an Apple Watch or anything of that sort that will give you that cardiac output widget on the Apple Watch. So that finding that she was noted at prompted some follow-up. How's your sleep? I've leaned into the 4 buckets, right, for the epigenetic factors. How's your sleep? Sleep was actually relatively good. So I was looking for a sleep. The dominoes line up: the stress leading to poor sleep, leading to increased caffeination, leading to the observed heart issues. Sleep was relatively well managed. Caffeine intake was down to 8 ounces of coffee in the morning, but her stress is through the roof. Further questioning on that. She's married, lives with a husband who is, drum roll, 1 week sober, diagnosed alcoholic, with repetitive lapses and relapses over the years. They have 2 children. One child is 14, the other child is 4. I noted that the time of the onset would have been when the other child was, the first child was young, and that was the one that was in the tub. And then you've got a 10-year span between the kids. And I'm just imagining the possibility that, there was some questions of whether or not to have a child and continue that pregnancy, the possibility that there were all kinds of things. So I left that door open for her to explore also, and to report to me if she felt comfortable with it. But, I'm not her therapist at the end of the day in that. But I wanted her to feel comfortable enough talking about that and to feel that she was being heard. I also made a bit more specific door opening about the possibility of physical abuse and or emotional abuse at the hands of her husband, given that he is substance dependent. She denied, and I left the door open there, and moved on regarding her past health history with that. So, let's see. Welcome in, Jerome. Welcome in, Bill Martindale. Jerome, the Zoom link would have appeared in your email earlier this week. And what do I believe is the method of action for acupuncture? Very briefly and very topically, since I don't want to get too off-piste here, I would suggest that the most consistent notable benefit I see with acupuncture is it's a place for people that are undervaluing time to themselves, to lay down and be quiet and let somebody else take care of them. Put hands on them, administrate in some way that is somewhat interesting, apparently compassionate, and let somebody put them in a caring environment. I think that probably is the most consistent benefit that I see. At the local level, I've always been fascinated by Helene Langevin's papers that showed that with dipping and twirling acupuncture movements under ultrasound, you can see the superficial fascia being tugged on with those movements as you move the needle. I believe, if memory serves, 4 to 6 centimeters distant from the point of the needle. And in my own mind, with my own biases, when I combine that with the multiple sets of data out there going all the way back to Ron Melzak, I think it was his paper, suggesting a 70 to 80% positive correlation between commonly needled acupuncture points and myofascial trigger points. And when I lay down on that, the stechofascial manipulation centers of coordination, there's an interesting, I find, correlation between all of those systems. Probably, I think what we're looking at is the blind man on the elephant, hands on the elephant. And we're trying to make some sense out of that. We're looking at all of these points. And I think the best current available science would suggest that what we're looking at is a mechanical interface issue with peripheral neurology in that particular tissue. So there you have it, Jerome. That's my 2 cents worth. I'm open to discussion there, but I'm going to move back now to our case of the week. The case of the week, this 41-year-old veterinarian, we just covered the history. Now we're moving on to the physical examination. To cheat, I'm going to go back over here. Pull her details up and make sure I'm HIPAA compliant. So I am on the, Jane will not take the person's name off the top there. But then our physical exam, let's see, let's make sure I didn't overlook anything. She was positive on the PHQ-2, which is buried in my intake form. So that 2-question depression inventory, she was positive 2/2 in that. So that opened the door for a bit more communication about what it was that during the last month has made her feel down, depressed, or hopeless, or have little interest or pleasure in doing things. She smokes 5 cigarettes a day, also managing her stress using that. Her stated desire was to be free of chronic pain and immobility, wants to be able to chase her 4-year-old around and move freely without always thinking about how she's moving to avoid pain and injury, wants to feel strong and wants to feel safe in her body. There's that safe word again, always makes us lean into the top-down issues. So many of you that have played with me over the years in that regard will recall a story I talked about some point of standing outside of the treatment room doors. I walked in, taking a deep breath, and for whatever reason, the first thought that came to mind was find the threat. Find the threat. Find what is the most acute threat. So in this particular patient, as I go through the history, she's looking a lot like a top-down patient to me in many ways. And at that point, the leading indicators for me are that she's got primarily a top-down driven issue. There's a lot of support there in a person with a 10-year chronicity of back pain that she's going to have, at least in part. A lot of it is going to be top-down phenomenology. So one of the things I've got right on my desktop is a QR code for the Curable app. That QR code for the Curable app is that's some of Adrian Luo and others that have put together that app, and I find that it is probably the industry standard right now for helping our patients with top-down issues and pain, depression, anxiety, comorbidities to leverage a CBT input on that. And they can get it for free using your own, you can set up an account, and then your patients can get it for free for 6 weeks. They can then do group classes on there for a little bit more. They can then do they can also do individual virtual meetings as well with a therapist. Okay, so now we move on. Mark, you were unmuted there for a moment. Do you have a question? You'll need to unmute again, brother.
Okay, here, I'm throwing in before you do it, but to me, a positive, you haven't gotten to this yet, but if she has a positive Laslett test, which I also use that and appreciate that, that means her SI is unstable and the ligaments are damaged. And
no.
You don't think that's the case?
Nope. All it tells us is that there's nociception at the SI joint.
Yeah, but how are you creating the nociception by stretching ligaments? And my take on it is, if you have a positive Laslett sign, you absolutely should not be doing high velocity manipulation to that joint. It's like, and people confuse SI dysfunction or SI misalignment stuff with true SI pain, which is what Laslett tells us. So
Yeah, I would agree with you. I would agree with you partly there. Sorry, you were breaking up there for a bit. I would agree with you in part there as well about the manipulation. The way that I would line those dominoes up, Mark, and this is according to my reading of Laslett's work and the other work regarding the SI that I'm aware of, Fleming's work and such, is the Laslett cluster will give us an idea of whether or not there is nociception at the SI joint. And then the next place in the clinical algorithm that they would work on, we'd ask the question, why? And I think you've got a very good, one very good possible reason for nociception at the SI as a hypermobility construct. And that is at least one that could happen in a variety of different circumstances. Perhaps that individual is pregnant and in last trimester or first few months after delivery. It could also happen in people that are, Beighton index 4/9 or greater, or have a history of Ehlers-Danlos syndrome or some sort of hypermobility issue. But all of that should be preceded with a question of why is the SI talking? And one of the primary things that we need to rule out from a disease standpoint is some sort of sacroiliitis. So does this patient have any particular past health or family health issue that gets us interested in the SI as maybe an early onset or something of that, some sort of onset with a autoimmune issue, and there was nothing in her prior health history and nothing in her past health history, and moreover, her symptoms began with an actual movement. I did not note that she had an MRI within a year of the original injury that did note a disc injury, but did not show any kind of nerve root involvement. In that particular situation, also, she had an X-ray that was performed this year, just a few months ago, and did note some sclerotic changes at the sacroiliac joint, and more on one side of the sacroiliac joint. And it also noted a 1 centimeter anatomical leg length disparity. But it did not note any changes in the sacral ilia or the ilia or the SI joint. So the SI joint was level, at least in a supine position where the MRI was taken. But the femurs were different lengths. So that does lean into a bit of the possibility of we have some sort of sacroiliac dysfunction. What would we as chiros or physical therapists do for that? Well, typically we do a manipulation procedure, and chiros are taught 6 ways from Sunday how to manipulate an SI joint. This patient, by the way, on physical examination, leading into all of those things, was Beighton index 4/9, so she is a bit potentially hypermobile. But let's continue on now and get into our physical examination. So with the exam, The significant findings, on motor, she had subjective and objective deficits in the right L5 myotome, and in the repetitive single leg sit to stand, she had objective deficits in the left leg. We were not able to perform the instability testing because of pain. When I moved her into McKenzie testing, she was very reluctant to perform anything in extension. When she was in standing and performed extension, she had pain at CC. When I put her in prone, she had pain at CC, and she was unwilling to progress into that any further. So I've got some reasonable data there to suggest I've got an extension pattern. I did put her into a McKenzie flexion movement pattern. That did not change her CC, which was merely standing up. Just standing would give her the pain. I trialed a static openers on both sides, and that didn't change it at all either. What did change it? My visual observation was the patient was in a pronounced anterior pelvic tilt. She had a large Q angle. She did have a prior history of lateral release in one knee after dislocating a patella. So I started to imagine that I'm looking at a potential instability pattern overall that is potentially historically affecting a lumbar and sacroiliac segment with a top-down primary driver. And my first goal in that first treatment is to develop a narrative that makes sense to both of us, patient and me. And within that narrative, I have to support it by providing some sort of movement. First, I have to give the patient a story that they can believe. And I will continue to say that it doesn't matter if it's right or wrong. If the patient doesn't trust you, even if you are right, then or if your story doesn't make sense, then you're not going to get much benefit with that patient. But we develop a narrative, convey that narrative to the patient of what you think is going on. And then based on your CAP, your clinical audit process of testing your inputs into that system and seeing if they modulate the index test, then you give the patient agency with something that they can do. So you send them home after that first visit with an understanding of what's going on in their body and something they can do to help themselves. That's job one. In this top-down patient, the things that with some bottom-up contributors, but the chief threat, I think, is top-down. I want to help manage her stress that is contributing. So I've got her on the Curable app. There's input one. In our narrative and discussing those particular possible stress inputs, I ask when her symptoms come on, and it's after prolonged standing in her workday. So I want some sort of input that she can do during the day when she is standing. She also has pain with prolonged sitting. So I want some sort of input that she can do there. Those things have to do with creating a mindfulness about what's going on in her body without creating hypervigilance. So we lean into that with some mindfulness type meditation. So I kicked her onto a few different apps to get a regular process on that. and I leaned her into breath work or anything that increases her breathing to a deep breathing status, which she's not doing right now. She's not doing any kind of exercise. She doesn't have any kind of athletic background. So she's naive to a lot of exercise. So one of the interesting things about exercise and mindfulness meditation, compassion meditation, and other types of meditation, and secular breath work is they all involve deep breathing. And deep breathing, when you lean into that even more in the literature, that oscillates around about a 4-second inspiration and a 6-second expiration. So a prolonged expiratory tendency. And it's during that we see, when that trend happens, a decrease in sympathetic nervous system tone and an increase in parasympathetic nervous system tone. If we take that half a step further, there is research that shows that in that sympathetically upregulated state, we will have upregulation of inflammatory cytokines and things like cortisol. When we increase parasympathetic nervous system state, we see a decrease in release of those cytokines from the spleen and other areas. So one of the inputs that we want on this particular patient at home, her agency, is going to be breathing in that particular way. So during the day, when she feels pain, don't just ignore it. Don't over focus on it, but apply some sort of intervention. In this case, a 4-second in breath and a 6-second out breath, and then try to build that into her day while she is to continue that. Thank you, Jerome. I'm just reading your input there. I'll cover that in just a moment. So I've got her doing that. Now, how about her bottom-up issues? In standing now, as I'm giving her her review of findings, she's been standing for a bit and she's starting to move around and she's a bit uncomfortable. So now I've got her in a testable state. We've got her in an index position. So I coach her into a little bit of a posterior pelvic tilt and a little bit of tone in her with kinesthetic cueing in her lower abs. And when I nudge her in that particular direction and leave her there for more than about 30 seconds, she reported that her pain was getting better. And she smiled and she shook her head and she's like, wow, is it that simple? And I don't know if it's that simple, but that is at least something that she can do in the moment to help with that. Okay. So to help foster that, I moved her into a DNS pattern there, and layer log rolling. And then here's where we have the intersection between breathing and bracing and posture and pain and stabilization. All of those things were in the boxes that have been checked in this particular patient workup. So I sent her home with that. Now, a sign of things to come. The process that I generally use to progress that when I see it in a patient leans into heavily on the DNS stuff. I like Evan Osar's approach of the DNS stuff with his log rolling to wall bug to 2 further progressions of the wall bug that both involve in the log rolling position, elevating the pelvis off of the floor, getting the sacrum up off of the floor, which we're really focusing on transversus abdominis and low ab incorporation there. And then I take that from the knee bent position to a knee straight position, and I can take that out in supine and do a hollow body position in supine, and then progress that to a pike position, and then progress that to legs overhead into something that starts to look like plow pose from yoga. And that we can then, depending on the patient, stand them up and put them hanging from a bar and move from the hollow body position hanging from a bar to a knee raise position, to a knee curl up position in the beginnings of an inversion, to a pike position, to a straight inverted position hanging from a bar. Again, depending on the patient. I don't think this patient's a particularly good candidate for that. But I do think it's fascinating, and we will continue that work with this patient over, well, I'll see you this week, and we'll do a follow-up next week at 9 o'clock. Jerome says your clinical workup and process sound to be in line with the recent WHO guidelines. Indeed, I reviewed those and was pleased that it looks like I'm at least in agreement with the most current clinical guidelines from large organizational bodies. So nice to know that I'm still between the lines on that, not too far afield. As far as other items that have come up, those of you that are on, that are members, I will share with you, or Jerome, you can do this yourself, share in the community a paper from this past week that was released. This was actually, it was released in September of 2023 in the Journal of Orthopedic Research in Spine. Is that right? Yeah, JOR Spine. It is full text available. Look for the link in the community on the membership side of NeuroCentric approach with the online academy there. If you're unfamiliar with that, follow the links here. Go become a member, for God's sake. It's stupid value. And you get to play a little more deeply together in a group process here with all of us. And in addition to all of that, you get $100 off of any of our future in-person courses. This particular paper was entitled Mechanical Crosstalk Between the Intervertebral Disc, Facet Joints, and Vertebral End-Plate Following Acute Disc Injury in a Rabbit Model. The rabbit model is a valid and reliable model for investigating lumbar disc issues. At arm's reach, when I first read this paper, the choice of mechanical crosstalk, I thought to be, another one of those clickbaity kind of things. I don't know what mechanical crosstalk means. I don't know that we have an operational definition there. But the main thrust of this paper is it's in agreement with other research that has shown that when you have an injury at a lumbar disc, which was the first domino that they set up in this, within that rabbit model, they can provoke a disc injury by sticking a certain gauge needle in the disc, and then you will observe a predictive degenerative process over time in the disc. But then they noted, some researchers noted that then causes or is associated with, I should say, the important designation there. Some research shows that you will also see downstream as the degeneration progresses, typical degenerative processes at the end plate and at the facet joints as well. But it's also been noted that when you don't injure the disc, but you do immobilize the disc, you also see those kinds of changes in some of those structures. The end plates will change and get thicker when you immobilize the disc. The facet joints start to exhibit osteophytes. It's kind of fascinating. So I think we're looking at multiple signaling processes, some of them probably mechanotransduction, some of them probably through tension in the cytoskeleton and the extracellular matrix, where we'll have the mechanical tensions. That's Don Ingber's tensegrity model going all the way back to 1995 when that was published in Nature. But when you have a change in that cytoskeletal arrangement, the microfilaments and such, you'll have mechanotransduction that causes fibroblasts to be recruited to an area to deposit a payload of collagen. Well, those fibroblasts are also recruited by chemical signaling, which is probably another thing that we're observing in these kinds of models. That will, that kind of chemical signaling, typically one of the first dominoes in the chemical signaling is going to be tumor necrosis factor alpha. And then downstream, you'll get interleukin 6, interleukin 1 beta, and a handful of others, but those are the ones that are best studied that I'm aware of. And that in turn will cause other cell signaling processes like releases of vascular endothelial growth factor, which causes blood vessels to grow into places. That's important in things like disc injury, because you then have blood vessels that grow into previously avascular areas like the interior of the disc. It's important in tendinopathy models because you'll have blood vessels to grow from the tenosynovial sheath where there are blood vessels into the interior of the tendon where there aren't blood vessels. When the blood vessels go, there's also release of brain-derived neurotrophic factor and other nerve trophic factors that will cause the nerves, sensory neurons typically, although sympathetic nerves also run in tandem with them. They'll piggyback on top of the neurology. So now you've got a neurovascular input into some of these areas. And then the sensory nerves, as part of that inflammatory cascade, will then become sort of the controllers of the ongoing inflammatory type of response. You add to that, in this particular paper, they observed that the cartilage didn't change. They didn't point out that in other research, when you injure in an experimental model, injure cartilage, and then you unload the cartilage, either in vivo or in situ, when you unload the cartilage, it will tend towards improvements in the anabolic nature of that cartilage matrix. Remember that cartilage matrix is essentially avascular. So you're working then with aggregans and proteoglycans, and the metabolic processes there, the homeostatic process, is primarily driven by matrix metalloproteinases. And the last that I did any kind of research on this, there were something like 24 of those that have been identified, and they're in a scale tilting process of that either tilts towards catabolism or towards anabolism. And that's kind of a fascinating tilt, because in those papers, if you injure cartilage up to a certain point in an individual or in an animal, you will observe, if you then apply that kind of unloading process, a anabolic process. And if you injure the cartilage beyond a certain point, you will not see that corresponding change from unloading. It will be a net and continued catabolic process. So that then brings us around to some of this stuff that I'm trying to bring into NCA, of an understanding of what we're better understanding of what we're learning into aging and longevity research. And this is where Wensawa and Judith Campisi's work with senescent cells and inflammatory cytokines and painful discs and what we see there. All of that tends to move us into a way of seeing that the individual's overall health can be potentially changed by with exposure to oxidative stressors, and those are our 4 buckets of epigenetic influence that I've been talking about. So that's when you start to see those kinds of things in an individual, it's important to lean into those 4 buckets and see if there are other areas that we can be contributing in that patient for that patient's behalf to help to manage pain. So there's a nice little arm's length look at things. We are 6 minutes overdue on an hour-long visit here. Does anyone have any questions before I close this off? Again, if you have not joined us yet on the NeuroCentricApproach.com, there's our links there to the online academy where we have over 35 hours of online continuing education for a single low price, or if you want to get your feet wet with it, it's very cheap CE for you to get for a monthly price for a period of time and test it out. And your lifetime membership will get you $100 off of future in-person courses as we start to spool those up. Okie doke. Questions over here on Zoom? Questions over here on Facebook Live? All right. Thank you for joining us, everybody. I very much appreciate your curiosity. Stay curious in the meantime, and take what you've learned and go out there and help some people. You guys be well. Happy holidays, and I will see you next week at 9 o'clock Pacific Coast time.